everyone. I'm Masaki Mizushima from Yonemori Hospital in Japan. Thank you very much for inviting me to the conference. I'm going to talk about robotic arm-assisted total knee replacement for Japanese patients. Yonemori Hospital is located in Kagoshima Prefecture in the southwest of Japan. It is a private hospital with 506 beds, which has two main departments, orthopedic surgery and emergency medicine. We carry out around 3,500 orthopedic surgeries a year. The Mako system became to be available in Japan from June 2019. Our hospital installed the system in October of the year. 441 arthroplasties have been performed with the Mako. I have performed 621 Makoplasties and have used the Mako in 97.5% of my primary total joint arthroplasties. In TKA, robotics offers a number of advantages. It allows detailed planning using CT, and the plan can be fine-tuned during surgery. Bone cutting can be performed accurately and safely without the need for guiding instruments. It was not just a straight cutting system. Preoperative planning using CT is accurately and safely reproduced. I'm going to talk about the literature on soft tissue protection and early post-operative recovery. This is a report on the accuracy of surgery using cadaver. Robotic arm-assisted surgery was 4.2 times more accurate in cutting bone and 3.2 times more accurate in implant placement compared to conventional TKA. This is a report of iatrogenic bone and soft tissue trauma. In robotic arm-assisted TKA, the knee joint is divided into 4 areas, which are visually assessed and classified intraoperatively. Less soft tissue damage is reported than with conventional TKA. Compared to conventional jig-assisted TKA, robotic arm-assisted TKA reduced postoperative anemia and was associated with less postoperative pain, faster functional recovery, and shorter time to discharge. The 1-year post-operative Womack score shows a significant improvement in the total and physical scores. I will talk about 100 cases of Mako total knee that I performed last year. Mostly OA, 80% female. The average age is 76.5 years, which is probably older than your countries. I have chosen to use cement 90% of my cases last year. The clinical scores are shown. Preoperative protocols are introduced. Epidural anesthesia, tourniquet are used. I also use intraoperative intra-articular injections and tranexamic acid, drug for DVT prevention. Duloxetine for preoperative central sensitization. The medical total knee surgical procedures. Surgical approach, arrays and checkpoint setup, bone restoration, joint balancing, bone preparation, implant trialing, implantation, and closure. The surgeries take between 60 and to 100 minutes, with 5 cases up to the first learning curve. With experience of over 100 cases, medical total knee now takes about 1 hour to complete. Performing TKA precisely in 50 minutes or less is beneficial to the patient. Post-operative X-ray evaluation at 4 weeks. There are a few cases of outlier in valgus. In these cases, the tibial implant sank due to osteoporosis. Recently, cement fixation has been used more often than before. Of course, there will be a significant improvement in post-operative coronal plane. Coronal plane alignments, compared to manual TKA or TKA using navigation. In many cases, the preoperative planning and the actual size of the implant use coincide. In all cases, the implant size were within one size of the plan. Rapid improvements of range of motion is achieved in both flexion and extension. Good postoperative ROM in flexion is achieved by reproducing TEA and maintaining PCO. Dynamic joint balancing provides a good control of the extension gap. The 9mm insert is used in most cases and is less likely to cause flexion contracture. In the literature I have just referred to, there was a topic about faster post-operative SLR. The morning after the operation. There's also analgesic effect on the epidural anesthesia, but many patients can raise their legs. The medical records shows that 57% of patients had a leg lift the morning after surgery. On the morning of the second postoperative day, the rate is 75%. "81 years old female. She became to be able to walk with a cane in the evening, the day after the operation. Four weeks after surgery, with safe postoperative rehabilitation, walking and stair climbing can be achieved successfully within 2 weeks. What do you do to perform a good TKA? A number of topics have been discussed so far. I cannot explain them in detail this time, but in alignments, neutral alignment is safer. The placement of the tibia in internal rotation must be avoided. In valgus knees, the valgus tends to remain after surgery. In ligament balancing, medial laxity reduces patient satisfaction and has a negative impact on postoperative knee function. In bone cutting, it is necessary to avoid excessive elevation of the joint line and to create an appropriate gap for good function. With Mako, you can put a lot of thoughts into your surgical plans and reproduce them accurately. 81 years old female. She has a valgus knee that has undergone an osteotomy 20 years ago. Thus, the surgery was completed without valgus reflection contracture. 9mm insert was also put in this case. 71 years old female. Due to rickets, she had suffered since her teens from varus deformity with femoral bowing. Bone cutting vertical to the mechanical axis of femur might damage the attachment of the lateral ligaments. The femoral and tibial cutting were adjusted in varus, and the plan was modified with a slight internal rotation of the femur to avoid medial laxity. The rotation of the tibia was determined using the long technique. It is also easy for Mako users to check intraoperatively for over external and internal rotation. 9mm insert was also used in this case. With the Mako, I am able to perform TK with less stress, even in cases with such severe deformities of Japanese patients. The summary is on the slide. Thank you very much for your attention.